Twin pregnancy, monochorionic pregnancy. Diagnosis of monochorionic twin pregnancy. How is monochorionicity diagnosed prenatally, and what is the accuracy of prenatal ultrasound chorionicity allocation? All women with a twin pregnancy should be offered an ultrasound examination between 11 plus 0 weeks and 13 plus 6 weeks of gestation, crown rump length 45 to 84 millimeters, to assess fetal viability, gestational age and chorionicity, and to exclude major congenital malformations. Chorionicity should be determined at the time the twin pregnancy is detected by ultrasound based upon the number of placental masses, the appearance of the membrane attachment to the placenta and the membrane thickness. This scan is best performed before 14 weeks of gestation. A photographic, thermal copy, record should be taken and placed in the patient's notes documenting the ultrasound appearance of the membrane attachment to the placenta and an electronic copy stored. If there is uncertainty about the diagnosis of chorionicity, a photographic record of the ultrasound appearance of the membrane attachment to the placenta should be retained and a second opinion should be sought. If there is still doubt in the diagnosis of chorionicity, the woman should be referred to a specialist without delay, as chorionicity is best determined before 14 weeks of gestation. On ultrasound, the fetuses in twin pregnancies should be assigned nomenclature: upper and lower, or left and right, and this should be clearly documented in the woman's case notes to ensure consistency throughout pregnancy. What is the outcome of monochorionic compared with dichorionic twin pregnancies? Clinicians and women should be aware that monochorionic twin pregnancies have higher fetal loss rates than dichorionic twin pregnancies, mainly due to second trimester loss and, overall, may have a higher risk of associated neurodevelopmental morbidity. Optimal screening for chromosomal abnormalities, structural abnormalities and other fetal complications in monochorionic twin pregnancies. What is the optimum method of screening for chromosomal abnormalities in monochorionic twin pregnancies? Women with monochorionic twins who wish to have aneuploidy screening should be offered nuchal translucency measurements in conjunction with first trimester serum markers, combined screening test, at 11 plus 0 weeks to 13 plus 6 weeks of gestation, crown rump length 45 to 84 millimeters. In women with monochorionic twin pregnancies who miss, or who have unsuccessful first trimester screening for aneuploidy, second trimester screening by the quadruple test should be offered. Early data with non-invasive prenatal testing are encouraging, but results should be interpreted with caution until larger studies have been carried out. What is the optimum method of screening for structural abnormalities in monochorionic twin pregnancies? All monochorionic twins should undergo a routine detailed ultrasound scan between 18 and 20 plus 6 weeks of gestation, which includes extended views of the fetal heart anatomy, as recommended in the Fetal Anomaly Screening Program screening of a singleton fetus. What is the optimum ultrasound regimen for monochorionic twin pregnancies? Fetal ultrasound assessment should take place every 2 weeks in uncomplicated monochorionic pregnancies from 16 plus 0 weeks onwards until delivery. At every ultrasound examination, liquor volume in each of the amniotic sacs should be assessed and a deepest vertical pocket, DVP, depth measured and recorded, as well as the umbilical artery pulsatility index, UAPI. Fetal bladders should also be visualized. From 16 plus 0 weeks of gestation, fetal biometry should be used to calculate an estimated fetal weight, EFW, and the difference in EFW calculated and documented. As the risk of selective growth restriction, SGR, extends to delivery, this should be performed at 2 weekly intervals until delivery. What are the optimum methods of screening for specific complications of monochorionic twin pregnancies? Screening for TTTS by first trimester nuchal translucency measurements should not be offered. Women with monochorionic twin pregnancies should be asked to report sudden increases in abdominal size or breathlessness to healthcare professionals in their secondary or tertiary centers, as this may be a manifestation of TTTS. Screening for TTTS should be by ultrasound examination from 16 plus 0 weeks onwards, at 2 weekly intervals, noting and recording fetal biometry and liquor volumes, DVP. Screening for twin anemia polycythemia sequence, TAPS. TAPS should be screened for following fetoscopic laser ablation for TTTS and in other complicated monochorionic pregnancies requiring referral to a fetal medicine center, such as those complicated by SGR, by serial middle cerebral artery peak systolic velocity, MCAPSV. At each scan from 20 weeks of gestation, at 2 weekly intervals, onwards, calculate EFW discordance using 2 or more biometric parameters. Liquor volumes as DVP should be measured and recorded, to differentiate from TTTS. Umbilical artery Doppler evaluation in monochorionic twins with SGR allows definition of prognosis and potential morbidity. In particular, those with absent or reversed end diastolic velocities, AREV, and cyclical, umbilical artery Doppler waveforms, intermittent AREDV, are at increased risk of perinatal mortality and morbidity. When should the delivery of monochorionic twin pregnancies complicated by TTTS take place? Delivery of monochorionic twin pregnancies previously complicated by TTTS and treated should be between 34+0 and 36+6 weeks of gestation. What are the consequences for the surviving twin after fetal death of the co-twin in a monochorionic pregnancy, and what is optimal clinical management? Clinicians should be aware that monochorionic pregnancies not complicated by TTTS, SGR or TAPS are still at risk of fetal death and neurological abnormality. After a single fetal death in a monochorionic pregnancy, clinicians should be aware that the risks to the surviving twin of death or neurological abnormality are of the order of 15% and 26%, respectively. Single fetal death in a monochorionic pregnancy should be referred and assessed in a fetal medicine center, with multidisciplinary expertise to manage these cases. Fetal magnetic resonance imaging of the brain may be performed 4 weeks after county twin demise to detect neurological morbidity if this information would be of value in planning management. Fetal anemia may be assessed by measurement of the fetal MCAPSV using Doppler ultrasonography. Women with monochorionic twins should have timing of birth discussed and be offered elective delivery from 36+0 weeks with the administration of antenatal steroids, unless there is an indication to deliver earlier. It is appropriate to aim for vaginal birth of monochorionic diamniotic twins unless there are other specific clinical indications for caesarean section.